Hello, everyone. Welcome to this IHE policy webinar on the patient voice. Thank you for joining us. We'll be starting in just a minute or so as people are joining from the lobby. But thank you very much for joining us at this event. So I'll just wait. And Chris, if you're on, if you could make sure to just admit all as people come in.
Yeah, and I changed it to auto admit now.
Okay,
So,
great.
Great.
Okay, thank you. So thank you. Hopefully everyone can see the slide that I've presented. Welcome. The Institute of Health Economics is very pleased to have this webinar with our colleagues from the Health Advocates Office, Care Opinion Alberta, the Imagine Citizens Group, Health Quality Alberta, and Care Opinion UK. I'd like to provide a land acknowledgement. It's on the screen presented for you, and certainly acknowledge, and you can in your own way, the territories I know that people are currently residing on across the country. The Institute of Health Economics acknowledges that we're located on Treaty 6 territory, the traditional and ancestral territory of the Cree, Dene, Saulteaux, Nakota Sioux, and Blackfoot, and it's home to also Métis settlements in the Métis Nation of Alberta, regions 2, 3, and 4. And we make this acknowledgement as an act of reconciliation and gratitude to those whose territory we reside on or are visiting, and whose histories, languages, and cultures continue to influence and enrich our community. And we at IHE acknowledge the harms and mistakes of the past and the enduring effects of systemic racism. And we dedicate ourselves to creating a safe and inclusive space, which I hope this is, that strengthen collaboration, build respectful relationships, and engender change. It's really a pleasure to be able to have you all join us today. We're going to be focusing a lot on a really unique platform that I'm a huge fan of, which is the Care Opinion platform, which evolved in the United Kingdom and is spread around the world, including to Alberta and Canada. We'll be having some opening remarks from Catherine Douglas, our health advocate in Alberta. And then the main event, I think, is James Monroe, who's a longtime colleague, but had the initiated Care Opinion with colleagues in the UK and is now the Director of Research and Development after moving on from being CEO for a long time. We'll have a short break after James with questions, so certainly welcome you to put those in the chat, the Q&As, and continue to put those in, and we'll try to get to as many as we can. Then we'll have a presentation from Don McLeod, Executive Director of the Imagine Citizens Network, and has really been leading a lot of the efforts in Care Opinion Canada and the Alberta efforts, and there's been some really exciting developments there. And along with him, there'll be some comments from Dale Gregory, who is the Executive Director for Caregiver Alberta, which is a partner in that effort. And Molly Cole, we're very pleased Molly's able to join us from Health Quality Alberta and is Executive Director of Health System Improvement, and she'll provide a few comments on what HQA is planning in improving engagement with patients and from their perspective. And I think we'll have a fair amount of time for questions. We have 90 minutes, and I don't want to, that this will be useful hopefully learnings for everyone and sharing. We will be posting all sorts of links that are going to come up that will be shared with you afterwards. You are muted, frankly, but certainly use the functions, the Q&A function that is available to you, and the comments function as well, if you want to provide comments as you go through. But I will pass over to a longtime friend and colleague, Catherine Douglas, who is the health advocate for the province of Alberta.
Thanks, John. Welcome, everyone. It's wonderful to be here together with you through the magic of, well, we used to say magic of television, but I think it's the magic of technology today. And so happy Thursday. We're almost there to the end of the week. Wanted to just set the stage a little bit for you as we're expecting some fantastic speakers to come as well. Someone there's not having any sound. Oh dear. So let me tell you a little bit about what our office does. We are the health advocate. We are also the mental health patient advocate. And so we hear from patients, families, staff every single day about what their experiences are within the health system, the mental health system. And of course, it's all of what we do, and take that information back in to being able to make changes to improve our health system. And so from our perspective, it's an essential piece of work to do, but it's not just essential for us, it's essential for everyone to be able to take a good look at what are people really experiencing. These people are us, they are us, we are all consumers of the health system. And our patients are the people who can tell us exactly what experience they've had and how they view their journey through the healthcare system. In Alberta, we have such a thing called a health charter. It sets up the premise that we should have a partnership in healthcare at all times. So the health charter here in Alberta says there's some responsibilities for the system to provide, but there's also responsibilities for the patient to participate fully as well in this whole process. This sets up that partnership. And without that partnership, I would argue that effective healthcare cannot really be happening. And so I want you to be thinking as we go through the morning about that. I want you to think also about why we even listen. So why do we listen? We listen because listening builds trust and builds strong relationships and builds our knowledge of any given topic. Listening can help resolve conflict. Our office is always thinking about how conflict can be resolved, but listening can help resolve that. Listening prevents from missing important information, important pieces that we may not get elsewhere. And we work very hard in the healthcare system to look critically at what we do in terms of quality improvement. And if we are not listening, we will miss points. And listening enables us to identify or anticipate problems. This was Dr. Google who taught me that, those pieces on listening as I was thinking about why do we have to listen so hard to what people's experiences are. And so I encourage you this morning to be listening to these amazing speakers and their experience, because the last point I wanted to make on this was listening empowers you as a leader. The more that we listen, the better leaders we can all be within the healthcare system. So when we start talking about patient experience, I'm thinking we want to pay attention to the fact this is a core pillar of healthcare. It's not an extra, it's not an add-on. It operates alongside clinical outcomes, alongside of patient safety. It's just not an add-on. Positive patient experiences are consistently linked to higher clinical effectiveness and better patient safety. So not only is this a core pillar, but it impacts the other pillars within healthcare. And it establishes benchmarks that make healthcare organizations more transparent and accountable to the communities that we serve. And as we move further and further in our healthcare journey as the world changes and our needs are changing. We have to be able to say to our communities, we're there for you. We want to continue with that trusting relationship that we always have had. And there are days when we feel very much like that trust is starting to erode. And so we really need to be able to listen hard to those people who are experiencing the system, and can tell us about that. So I want you to keep those thoughts in mind as we move into the discussion and hear from some of my amazing colleagues, and thanking IHE for hosting such an important discussion. So I'm going to leave you with those thoughts. I'm going to pass this to my new friend, James. I've been watching Care Opinion for many years, as I was just telling James a few minutes ago. And so excited to hear more about Care Opinion UK as well, because I've also been watching and following and participating as the work of Care Opinion has been happening in Alberta. So I wish you a wonderful continued session this morning. And think hard about the fact that we really do need to listen, and it's worth our while to listen. And I'll pass that on to James. So thanks for having me for a few minutes of your time.
Thank you so much, Catherine, and thanks for your leadership as health advocate. Catherine is not only the health advocate, but also the mental health advocate, which deals with those people who might have involuntary treatment and make sure they follow processes and to ensure that their rights are protected, as well as work in the seniors area. But I will certainly share that links and information to a lot of work that they do. Someone did ask in the question and answers, we are recording this presentation. We'll be sharing the links and the presentations afterwards, which we hope is ongoing food for thought. But yes, as Catherine had handed over, James, known James for a number of years, and he's really been a constant source of support for Alberta efforts and developments in this particular area. And certainly the work has, which I think he will get into, has expanded to other outside of England, other places in the United Kingdom, and as well as Australia and other efforts, and really fantastic platform that has grown over the last number of years. But over to you, James, and thank you so much for sharing your great journey with all of us in Canada. So I'll pass over to James.
Fantastic. Thanks very much, John, for inviting me. It's great to be here with everybody. It's lovely to see 104 people, lots of interest there. So that's really heartening. So, and of course, before I get going, just to acknowledge John's role was absolutely pivotal in the very, very earliest days of Care Opinion gaining a small foothold in Alberta. So you were there at the start, and you've been supportive ever since. So that's fantastic. So I've got some slides. I'm going to share the slides. I'll talk for 25 minutes or so. I'll probably rattle along at a bit of a pace because there's lots of interesting things to cover. Feel free to post chit chat in the chat, questions, awkward comments, whatever you like. It's always more fun if there's some interaction. So do ask questions. There are no stupid questions. So if anything's not obvious or something occurs to you, pop it in. We'll try and keep an eye on the chat and pick up questions from time to time. So feel free to do that. And let me just share my screen. That's the first challenge in any presentation. Hopefully you can see that okay.
It works great. It's thumbs up, James. So
great. Okay, we're there. Good. So I'm assuming there'll be quite a few people here this morning who are pretty familiar, as Catherine is, with Care Opinion. I've been keeping a bit of a beady eye on what we're up to for some time. But there'll be others for whom this is entirely new. So I thought I'd start off just by saying a few things about what Care Opinion is and how it works. It's a pretty simple thing, really. And then we'll go along and start to talk about how it feels to staff and what we know from emerging research about how care opinion might create impact in health services and how those impacts might not necessarily be the ones you would expect from an open online platform of this sort. So that's the plan, and we'll see how we get on with it. So just by way of background, Care Opinion is a non-profit social enterprise. So we're if you like, an NGO. We've always been a non-profit since we set up it at the start of 2005. We've been going just over 20 years. And as John mentioned, making, I think, slow but steady progress in the UK, a little bit of a foothold in the Republic of Ireland as well. Worked with colleagues in Australia now for about 10 years and well established, particularly in Western Australia, where Care Opinion is used across that state by all public hospitals now. And of course, in Alberta in the last few years, and it's been amazing to see the progress there. So let's just, so you've probably seen Care Opinion in Canada. This is what it looks like. It's a website, but it works on your phone and on your tablet as well as on your desktop, hopefully for people. And it's a site where anybody can come and share an experience of care. In the UK, we say in the last 3 years, so relatively recent experiences of care, and stories are shared by patients themselves, but sometimes by families, relatives, friends, visitors, supporters of various kinds. So all kinds of people can share those experiences. And in the UK now, we're up to about 750,000 stories of care online in public. I think there's probably no open repository of patient narratives of that sort in the world. And so, of course, it's become a resource for, let me just hang up there. I should say it's my granddaughter's first birthday today. And that's her mother calling me. So, you know, typically badly timed. So these stories are shared by people across the UK over the past 20 years. They're specific, they're timely, they're local in ways that we'll see. And currently we have about 16,000 NHS staff with logins, accounts on Care Opinion, who can set up email alerts and receive alerts and post responses to stories in their area of interest. And as you see on this statistic, about 3/4 of stories do get a response currently in the UK. That varies a lot by area. In Scotland and Northern Ireland, Care Opinion has become the system-wide platform in the NHS. Just like in Canada, we have a lot of health systems. We don't have as many as you. You have a ridiculous number of health systems. We only have 4, but they're all called the NHS. And 2 of the 4 have adopted Care Opinion now as, if you like, the system-wide platform of choice for all their services. And in those 2 health systems, the response rate from staff is around about 96, 97%. In the other health systems, lower, because there hasn't been a policy decision, if you like, to go in that direction. So just to explain how it works, people post their stories online. We moderate all the stories. That means we read all the stories and check they meet up our policies. And our policies are essentially designed to reduce the risk of harm, either to the story author themselves or the patient, if that's somebody different, and to staff. So we pay attention to issues like safeguarding and defamation and identifiability and those sorts of things. So moderation is a significant effort, but all stories are moderated to keep people safe. And then when we publish the story, we send out alerts to relevant staff, and people come back and post their responses. So quite often it'll just be one staff member, but sometimes stories span multiple organisations, multiple services, and then there'll be responses from different services. In Scotland, where care opinion is very widely used. I think the record is getting responses from 5 different organisations to a single story where there was a very long and complex clinical journey. And then, of course, authors can respond back to those responses, and sometimes that leads to a series of exchanges of clarification or whatever. Sometimes we step in just to say, okay, this has gone as far as it can, and we close it down. But generally, that there might be 1 or 2 responses back and forth in that way. Sometimes, of course, that leads on to an in-person interaction. Sometimes people use care opinion to establish a sense of trust in an organisation before they're willing to go and talk face to face. So sometimes that happens, and that, as we've said, creates an enormous amount of data as well, and then those stories can be used in reporting, in data visualizations. I'll show you a quick example of those, blogs and digests, and of course those are all then potentially available to a whole range of other actors. So it's not just the care providers who have access to this. After all, the stories and the responses are public, everybody can read them. So those tools are sometimes used by others in the health system, policymakers, system leaders of various kinds, other organisations, patient advocacy or organisations, national patient charities. But of course, again, researchers, educators, we'll see some of the research as we go along. Care opinions used in some medical schools, for example, and schools of nursing and teaching healthcare professionals, precisely because it's such a unique resource for learning about people's perspectives on care and their experiences. And it's very meaningful to students to be able to see recent encounters with the health system and the perspective of the patient in those. That's quite difficult to achieve often otherwise. But so we don't know who necessarily can use these stories. That's why we make them public, so that everybody can use them. That's the point. And different people can use them in different ways according to their interests and their skills and their particular expertise. So let's just look at the quick example of a story. This is a slightly unusual story, but it's very short, and I've chosen it precisely because it's short, but it's quite appealing. So this is a story that was told some years ago about the maternity hospital in Aberdeen. It was told about the neonatal unit. You can see that there. The story is linked to the neonatal unit. And an author called Karen, a new parent, posted her feedback. She said, "I recognise the amazing work in staff and neonatal do, but it's disappointing when you arrive for a cuddle with your baby and find they smell like one of the nurses' very overpowering perfume. Surely they should not be allowed to wear such heavy perfume around these little babies." So that's her feedback for the service. And here's the response from Nicole, who's the manager in charge of that, the nurse manager in charge of that neonatal unit. And she says, "Dear Karen, thank you so much for taking the time to bring this to my attention. Sensory stimulation, including smell, is so important for our vulnerable babies, and perfume is not an appropriate stimulant. I'll discuss this with the clinical team and can reassure you the practice has changed from today. Clinical staff will no longer wear perfume to work. Without feedback, nothing would progress or change within my service. Feedback is vital, so thank you for advocating as a parent for your baby." So not a clinical issue, but a fairly straightforward issue, and you can see handled in a very immediate and unambiguous way by Nicole here. She's put a little icon on her response to show that she's made a change. People have clicked to say they think that's a helpful response. And that it's interesting to reflect on the kind of impact a response like that, a story and a response like that might make on people who read it, and who those people might be. They might be obviously Karen, the author. She'll feel heard, that she'll feel she can make a difference, that her feedback matters. As Catherine said, her level of trust in the service is increased by this. It may have made a difference to Nicole, who responded and feels that she can speak truthfully to patients. She can do that in the open. She can make a difference in her service. It may have affected others in her team. They all feel now that, okay, this is what we do. This is a kind of modeling. This is what we do. We listen to what people tell us. We make improvements. We can use that. That's something we can do. We'll talk in a while about the impact of that more generally on teams. Nicole's boss maybe read it. He's maybe thinking, okay, that's a place where people are listening to patients, where they're ready to make improvements, where they care about the quality of their service and how people experience it, and so on and so on. You can see there, we sometimes call it the ripple effect. People tell us how these stories ripple out from the immediate encounter to impact on other teams, other parts of the organization, others in the system. And because they're public, they can ripple a long way. And that's fantastic. And then we can all learn from that. So we don't know how that ripple works. Some things ripple more than others. Of course, we had one story. It was about palliative care. It was a man and his wife who were able to be cared for together. One of them very close to the end of her life. That story ended up being read by 65,000 people within the first week, because just because it was such a moving and extraordinary story, and it's still online for anyone to read today. So we don't always know how the ripple effect's going to be, but there is a ripple, and people tell us about it in their organisations. And then you can see other people have clicked to say, well, I've had a similar experience. You can see the staff members who've read the story, learners, so medical students or nursing students have read it, and so on. So there's an attempt here at transparency. There's always further we can go. We don't feel we've gone far enough with this kind of transparency, but we'd like to do more with that. And then I talked earlier about how this creates these interactions as a byproduct, if you like, create a lot of data, and we can try and find ways to share that data in ways that make sense to people and allow them to interpret these stories in different ways and look across sets of stories. This is just a quick example, something we call tag bubbles. This is people tag their stories with what was good and what could have been better, and the tag bubble summarizes that. So this is a set of stories for this particular hospital group, and you can quickly see about the things that people are saying are good, the things they think could be improved, and straight away you'll see there's more green than pink. So there's more good than bad, there's more positive than negative in these experiences, and that often surprises people. And it turns out actually about 70% to 80% of stories posted on Care Opinion are positive. And we'll come back to the power of that positive feedback as well in due course in the research, because people are starting to get interested in what impacts that positive flow of feedback can have on the system. So that's that. And then we can summarize other things about how people feel about their health services as well. People tag the emotions, they add emotions to their stories. And we can summarize those in this kind of way. And of course, these visualizations, we try and build them so that you can navigate from the words to the stories. So you can click through, you can click on crisis here and click through and find the stories where people talked about feeling in crisis. So you can navigate there. They're not just a summary, they're a tool for exploration and curiosity, and hopefully stimulating a desire amongst staff to explore and to listen and to find opportunities for improvement. So that's what we're trying to do with these things. So how do staff in health services in the UK react to this? Well, the starting point is always anxiety. People are fearful of feedback. People feel that, particularly on the internet, it's about naming and shaming. It's about pile-ons. It's about people being told they're doing things wrong. Pretty soon, people discover that actually mostly people are telling them what they're doing right, and so people very quickly start to really value it. They value the unmediated authenticity, the rawness of people's voices, as you saw with Karen and her baby. People really value hearing direct. It's not mediated by a management layer. It's not analyzed. It's not digested by AI. It's just, this is what somebody said about your service. And that kind of immediacy, I think, connects people to their purpose very often. So people often say to us, it reminded me why I became a nurse, why I went to healthcare. It's reminded me why I'm here. It's connected me back to what took me to this place. So often that connection to purpose and to value is such an important part of what's happening. Patients are connecting people back because they're saying to staff, this is what mattered to me, this is what you did, this is how you made a difference. And that connection motivates people and reconnects them to why they chose healthcare in the first place. But you can see other examples, things people do here. People do all sorts of extraordinary things with the stories. This is on the left. You can see stories being printed out and pinned up on a board. People often do that. We see a lot of examples of that in the UK. People sharing the stories from patients with other staff and with other patients and visitors in their service, so people can see that they're getting feedback and they're being listened to. And then on the right, this is a funny one. We don't see this very often, but in this service, they've made mugs to celebrate when people get positive feedback in their team on Care Opinion. And that's a nice way of taking the feedback and using it, in a sense, as a way to engender a particular, foster a particular kind of culture of teamwork and celebration for good care and for doing things that matter to people. And we'll come back to that again, because that's also in the research. So here's a couple of, in the old days, we used to be on Twitter. Of course, these days, it's all gone a bit wonky and we tend not to be on Twitter. We used to get lots of nice feedback from health service staff and from patients through Twitter about the impacts of this kind of feedback. And this is just a couple of examples of those sorts of tweets, that people acknowledging the impact of positive feedback and then the impact they've had on patients, but then the impact that patients have had back on them. So there's the Karen's tweet, top left, that reminds me to mention reciprocity, that a lot of this is about establishing that sense of reciprocity, of mutuality, of actually we can care for you because we know things about healthcare, but you care for us at the same time in the things that you give back to us that remind us why we do what we do and reconnect us to our purpose and motivate us to do better. And that reciprocity is absolutely crucial, I think, in healthcare, and completely underestimated in most models of change, but absolutely crucial. So this is a very human-centric process, really. It's not an analytical process. I'll come on to that a bit more in a while. And then Ruth, this is down in Cornwall in the southwest of England. A nice tweet just saying, about the feedback from patient experiences. And funnily enough, once people get over their anxiety and concern, and they start to really enjoy it, but they also find that they're able to learn more as they go on and practice, if you like, from the negative too. So they become less defensive. They become more open to hearing, okay, well, this didn't go right. Why didn't it? What can we do? How can we fix that and improve it? So that's all nice stuff. Okay, so why are we doing all this? What's the point of all this? Partly we do it because we're having fun and it's interesting and we're learning loads of stuff. But here's our official reason for doing it, which is we want people to be able to share their experiences in ways that are safe and simple. So we know often it isn't safe and simple for people to share their experiences. People are scared, just as staff are scared to receive feedback, people are scared to give it. People are scared to be honest with health services in case it affects their care. And they also often think it won't make any difference. So why would they do it? So, and some of the stories that people tell are costly to tell. They're painful, they're difficult. They're stories where people have been harmed or traumatized. Those are difficult stories. So making it safe and simple is a particularly important thing. And we don't do it just to collect a lot of stories. This is not a research project. It is about creating learning and change. And so if there's not an outcome from this, then we failed. We want there to be learning and change across the system as a result of this. And that's what we're constantly looking for, is new ways to prompt that. So we've always been very keen on research collaborations, working with researchers in all kinds of different disciplines across the UK, but also internationally. We've worked with colleagues in the US and in Australia and other European countries to explore not just what people say, but also how care opinion works. So there've been quite a number of studies, and all the studies I talk about, you'll be able to find on the Care Opinion website. If you look down the bottom of any of the pages, there's a link to research. If you follow that link, you'll eventually reach our research outputs page. And there's about 50 studies now, either using care opinion data or analysing or looking at aspects of care opinion itself. And so I've just picked out a few to talk about this issue of, well, how does this work? How does it make a difference? How do we engender learning and change through this kind of open online feedback? And I've sort of reached the view in recent years that we can think about it in two different ways. One is feedback as information, and the other is feedback as intervention. And I'll start off by talking about feedback as information. And very often, this is very often where people start. This is, if you like, the traditional view of feedback, which is that it is information that tells us something we didn't know before, and tells us something terribly important, and it's a very good thing you've told us that, so we can do something about it. And the more information we collect and the more analysis we do, the more change we can create or improvement we can create in healthcare. And there's been some, I think there's a growing amount of research in this area, actually, particularly because of the advent of machine learning and more recently AI, because it's making it much easier to analyze those patient narratives. So 750,000 narratives is more than any of us can read, but the AI can read those pretty fast and answer all sorts of interesting questions about it. So here's an interesting study. This is actually pre-LLMs, so pre the current version of AI, but using traditional machine learning. This is from Alex Gillespie and Tom Reeder at LSE, who analysed 146,000 stories from care opinion. This was published about 4 years ago now, and they trained their machine learning to look for patient safety incidents. They wanted to find stories where people were reporting patient safety concerns, and that's what they did. And they were able to train the model quite well to do that. And then, having done that, they then decided to create a score for different hospitals across the UK, for each hospital for each year, a score according to how many patient safety incidents have been reported by patients on care opinion. And what they found was that score correlated with hospital mortality. So, if you like, patients know something about safety. Their stories correlate with mortality outcomes of the hospital. So that's in itself surprising to some people. But what they then did was they went on and looked at staff reports, patient safety reports logged through the national reporting system. And they did a similar exercise of constructing a score for each hospital for each year, and they found there was no correlation between staff reporting and hospital mortality. So firstly, we can say, well, maybe patients are better than staff at recognising safe or unsafe care. And secondly, we might ask why that is the case. And sometimes that might be because there are things that the patients can see that staff can't see. For example, what happens when you go home? What happens when you go home and then get readmitted? Things that just can't be seen or aren't noticed by staff or aren't seen as important by staff. But one reason they explore is the idea that different organisations have their own kind of risk tolerance. And if you work in an organisation that tolerates a significant amount of risk, then probably you'll end up becoming the same. You adapt to the culture of the organisation. Patients tend not to adapt to the culture of the organisation because they're not there long enough. They come in and out of the hospital, so their reports are unbiased by culture. And that's one reason why patient reports of the quality and safety care might be so important compared to staff reports, because they're not biased by the risk tolerance that develops in some organisations. This is not a published study, but an internal analysis from NHS England, trying to predict which hospital trusts in England will show a decline in quality in any given year. And they analysed a whole range of different potential predictors of that, and they found that the most important issue was staff engagement. And the second most important issue was real-time patient feedback in predicting a decline in the quality of care, which I thought was, again, particularly interesting, perhaps quite surprising how powerful patient feedback can be. And because of findings like this, there's an increasing interest in building AI models that essentially consume care opinion data and warn staff when quality might be falling or where there might be concerns in different parts of the organisation. And this particular one is being developed in Belfast in Northern Ireland, in Queen's University. We're working together with the university and the regulator in Northern Ireland to support development of an AI-based system as a sort of an early warning for unexpected falls in the quality or safety of care. So that's a sort of information approach to the feedback, if you like. It's about collecting the information, analysing it, looking at trends, predicting things, and so on. That's valuable. But I'm interested, perhaps more interested, in the other one, that feedback itself, irrespective of what it tells us, might be a direct intervention in the quality and safety of care. That actually, simply by giving feedback, people are changing something about the healthcare system. And I think that's happening too. So one of the best bits of research on that in recent years has been this paper from a group that that you might know from Yale and Wharton. Rachel Grob has been working in this field for a long time with Mark Schlesinger at Yale, and Ingrid Nemhart has been working alongside them, I think, in recent years. She's at Wharton, and actually we had them on one of our research chats. If you're interested in this, if you follow the research links on Care Opinion, you'll eventually reach a video that you can watch if you're particularly interested in this. But in this study, they look at how clinic managers, primary care clinic managers in the Northeast US are using patient narratives within their services to create change. So this is if you like, an ethnographic study. It's based on observing what people are doing with their narratives. How do they use this feedback to create change? And what they found, they ended up creating this sort of model, which looks a little bit complex, but the essence of it is here in the middle. And the essence of it is that managers who are able to use patient narratives to create changes in services are doing two different things. They're using those narratives to nudge the culture of the organization or the team. And at the same time, they're using them in a practical sense to identify areas for improvement action. So both of those things are important, the culture and the improvement projects, and they probably go together. But the culture one is particularly interesting to me, and that's why I mentioned earlier, you saw those mugs that they remained. I think that's a cultural intervention, that idea of, we'll celebrate when you get positive feedback on Care Opinion. We'll make a fuss about that. We'll look at why you got that feedback. What was it you did? Other people could copy that. Other people could do what you did. It's probably not very hard, and so on. That's a cultural intervention, thinking about what it is that people really value, that makes care good for them. And this whole area of the positivity of the feedback, it's a bit countercultural. I don't know what the Canadian health system is like, but in the British health system, for some reason, people much prefer negative feedback to positive. They think the negative feedback is where they're going to learn, where they're going to improve, where they're going to find the things that they need to fix and stop doing and tell people off for and things like that. And then you give them positive feedback, and they're not quite sure what to do with it. How do we use this? What are we supposed to do? Well, that's nice to hear, but what does it mean really? And actually, the positive feedback, I think, is completely undervalued and underused as a powerful lever for change. And in this study, which I was one of the co-authors on, we looked at 68 studies around the world of the impacts of positive patient feedback on staff. And And what we found was that you won't be surprised that these studies often report positive emotional effects for staff. They improve confidence, they improve pride in service, morale, but they also improved workplace relationships. This positive feedback improves the relationships that people have within their teams. They improved home relationships. They improved sickness absence, for example. So they had a whole series of worthwhile, valuable effects. In some studies, there was a suggestion that this kind of positive feedback might even improve performance of staff. So this positive feedback is such an important part of the intervention that patients are making. And this isn't my area, so I don't know much about this, but there's interesting work on things like the gratitude and the witnessing effect, that idea that when people witness an act of gratitude, even if the gratitude isn't directed at them themselves, it changes how they behave and how they feel about their work and what they do and how they relate to others in the team and so on. In a sense, it's the opposite of the incivility effect, which you're probably familiar with, that idea that it only takes one person in the operating theatre to be rude and shout at everybody for the performance of the whole team to drop for the next hour. That incivility effect is not necessarily widespread, but it's a concern I think in all healthcare systems. And if we can somehow do the opposite, the civility effect, the gratitude effect of letting people know how well they're doing, we can perhaps overcome some of the downsides of the incivility effect and improve the quality and the safety of care. What's nice about this is that this fits perfectly with what patients are trying to achieve when they tell their stories. So patients don't just tell their stories because somebody's told them to. They have their own reasons and their own intentionality about what they're trying to achieve. And this is a study from Oxford University, which showed that, this is obviously UK adults, but mostly people were trying to inform other patients about care. They were trying to praise the service and they were trying to improve standards of care. So positive pro-social motivations that people have. And in a follow-up study to this, a qualitative study, Fadila Mazandarani, who's now at Edinburgh University, published this paper based on interviews with patients who'd left feedback online, asking them what they were doing and why they were doing it and exploring their reasons for doing that. And she ended up publishing this paper, which is a terrific paper, and I commend it to you. If you only read one bit of research after this, I think this is the paper to read. She called it caring for care, that what patients are trying to do is try and care for the carers who care for them. And they care about the care that's given. And these are just a couple of indicative quotes from that study. Somebody saying the NHS is under such huge demands and everything else, but unless we tell them what's wrong, they can't put things right. That sense that, I'm part of the improvement team here. I can help you improve. I have to tell you what's wrong so that you can improve. And somebody else saying, I firmly believe that in a subtle and perhaps longer term way, I'm contributing to change. So this is not about being negative. It's not about being critical. It's about being a partner in healthcare improvement. So again, you see that mutuality, that reciprocity between not now necessarily at the personal level, but at the level of the system, at the level of the care that's provided, that I can help improve care for others through my feedback. That's caring for care. And what's fantastic now is we're starting to see that actually people who post their feedback are trying to improve care for others, and the evidence is suggesting they're succeeding in that, and that's working. That reciprocity is working. It's having an effect. So we can compare these different models of change then, that we have the informational model, which is I'd say the traditional model is a model in which patients are essentially discerning consumers, like in any other consumer market. They're consuming things, they're letting people know that they're good or not good. The feedback is information. Other people can choose to go to the same service or different. This would be the prevalent model of feedback, for example, in the US. The patients provide data. Our job is essentially to analyze it and present it and identify problems that need fixing and so on, or share it with future consumers. And in this model, we often don't really know what to do with positive feedback in terms of improvement. But in the relational model, which is this sort of more direct interventional model that I'm suggesting also exists, patients are not just consumers, they're concerned citizens who want to be active in improving the healthcare system. They're giving feedback not just to give information, but to create an intervention, to make a difference somehow. And they don't just provide data, they provide motivation, they provide energy, they connect people back to their purpose and help them to create change in that way. And the change occurs not necessarily through analysis, but through sharing and discussing the stories within teams. And therefore, in this model, the positive feedback can have multiple benefits, as we've sort of seen in the review of studies. So that I'm pretty much near the end now. This brings me to this slide, which is a screenshot from the Care Opinion website, and you can go and find this on Care Opinion. If you click the number of staff on the homepage, the number of staff who are listening, you'll see a chart a bit like this. And this is about, well, can we scale up impact across the whole health system this way? Because it's great to create impact within a single team or for a single individual, but we want to create impact across the whole system. What if we could shift the culture of not just a single team, but the culture of the whole system, even by 1 or 2 percentage points in the direction of being less defensive, more open, more ready to improve, for example? What if we could do that? That would be a substantial change. And so in terms of impact, we're much less interested in the number of stories that are being posted and much more interested in the number of staff who are reading them. That's how we think impact occurs, not through counting, oh, you've had this many stories, but through counting, yeah, but how many people have thought about them, have read them, have talked about them, have shared them, have discussed what we could do with them. So that's the bit we're interested in. You see here, there are some organisations now in the UK where there are hundreds of staff, and I think that's still not enough. We probably need thousands of staff in some of these organisations because they're big organisations who are receiving email alerts about their service, who are reading the stories, who are posting responses, who are hopefully then taking them to various quality and safety groups and discussions and so on. So that's what we're interested in, and we hear a lot from our subscribers about culture change, and I've just picked this as my final quote because it's something that really resonated with me. This is something that somebody from a trust in the south of England said, Alex Clements, who was leading on care opinion work in Hampshire and Isle of Wight in the south of England, and he said care opinion has changed culture in a way which is soft, organic, and relaxed, not corporate. So that sort of sense that this is a kind of bottom-up, outside-in approach to change. It's not a top-down managerial system design approach to change. It's much softer and more gradual and more iterative than that. But it's very human, and it's very much about values and mutuality. So that's probably enough from me. I'll stop there, and very happy to take any questions or comments from anybody.
Thanks so much, James, and fantastic presentation. It's going to be wonderful resources, and we will be posting afterwards along with the links to the articles to James, to everybody, so they can kind of explore going forward. I'm just going to pull a couple of questions that have come in already out of the chat, and then move on to just a short presentation about what follow-on we're developing in Alberta. But a couple of things came up. One about other platforms such as Facebook or Dr. Google, other particular things where people might be putting impact on Rate My MD, that kind of thing, which is used often in the States. I'm just wondering, if there's any particular connections of you reflecting against some of that information, of there's some other patient input platforms. I know you control it, but that's one thing. And also, if you just might comment on, I think the subscribers to the service fund this, they provide some financial input to supporting care opinion. I think there's some general grant funds or the government sometimes to fund, but also just the models of just comment on model funding. Just if you might kind of highlight those two quick questions before we move on. Thanks.
For sure. So we'll do the funding question first, because that's always interesting and tricky. So in the UK, I mentioned that two of the health systems use care opinion widely, and that's in those two systems we're funded directly by a central body. So in the case of Scotland, we're funded directly from the Scottish Government as a policy decision, and in Northern Ireland we're funded by the Public Health Agency. So those are sort of competitive procurement rules. So they don't just sort of give us money year after year. We have to sort of argue for it, if you like, but it's not direct from healthcare provider facilities. So it's done in that way. In England, that's not the case. We have a free level that we allow organisations to use that just has 2 logins and basic functionality, and that's used very widely by lots of organisations. So that creates work for us, but no support because that's free. But luckily, there are enough organisations in England now that do pay for a subscription, and that allows them then to have, as you saw, many more staff using the system, and it means we can support and provide support and training, and they have more features and so on. We haven't been able to, in England, persuade. There's still a vast majority of organisations who don't subscribe, even after 20 years, and that's just a constant struggle for us to try and move more of them to use care opinion. Sometimes it feels like we're in when we go north of the border to Scotland, we're living in the future, and when we come down south, somehow we've gone back 20 years and think, well, why aren't you doing this? Why are you not doing this? Anyway, that's how it is. On the question of social media platforms, other platforms, I think there are some significant differences that mean that the experience, both of patients as authors and of healthcare staff of those platforms, is very different to the experience of care opinion. One is the sort of, in a sense, the values and intentionality of the platform. So care opinion is a place where you come and you expect to be heard, you expect there to be a response, you expect to be able to make a difference, and where on the whole people are quite thoughtful and quite balanced about their feedback, and sometimes telling quite long, quite personal stories about their healthcare journey. On platforms like Google or Facebook or X or whatever, feedback is very often extremely brief. Sometimes it's extremely angry. There's not necessarily any expectation that the healthcare organisation will ever see it. And of course, the other thing is that it's unmoderated. And I think the moderation is key, because healthcare staff, why would healthcare staff want to go onto Google reviews or onto Facebook and respond to angry feedback about their service, where they risk a pile on from other people saying, yeah, we all said you were rubbish, and it's built in a different way for a different purpose, and it incentivizes particular kinds of interaction, I think. And care opinion is trying to incentivize interactions which are about learning and change. Not about clicks. So we're much less interested in the number of times a story has been clicked on. We don't, we have no advertising on the platform. We're not interested in, so we don't, we have no incentive to drive up clicks. Right. Our incentive is to drive up learning. That's the bit we're interested in. Right. So these are very different platforms, and that means the experience of healthcare providers using these platforms is very, very different too.
Yeah. Okay. No, thanks very much. I'm just going to move on, actually, Dawn, to outline to people about care opinion, the Alberta initiatives that are being developed, and then some short comments by Molly in regard to HQA's developments. And then I think we'll have some time, and I'll try and follow up on some of the questions that have been put on the chat at the end. But Dawn, over to you. But thank you James, a big applause on fantastic information that I think we're going to be able to follow up on. But they're fantastic, Don. It's working. So over to you.
Thank you, John, and thanks for the invitation to be part of this process and for your hosting, and Institute for Health Economics too. We're grateful for your partnership, and great to have Catherine and James with us this morning, as well as Molly and Daryl. I'll try to be quick so we can get to those questions and conversation that we want to have. But we did want to give an update on what's happening here in Alberta with Care Opinion. We're grateful for the support that we've received from the Alberta government, Alberta Innovates, and also the Charlie Fisher Memorial Fund. That was instrumental in us getting started and launched here in Alberta with Care Opinion. All right, my slides have frozen. There we are. So just a bit of background about who we are. Imagine Citizens Network is a citizens-based, not-for-profit. They're volunteer-driven. We've been around since 2015, and our purpose really from the beginning was to help create safe spaces for Albertans to share their healthcare experiences and to learn from those experiences over the years and to try to make change. And we've been doing that in all kinds of ways. We certainly have been traveling the province when especially in the early days before COVID. We would drop into public libraries in local areas or local community centers and invite people to gather with us and share their stories. And it was always a profound experience for us. And for people that participated too, they gave us lots of feedback about how meaningful it was, both to have opportunity to share their own experience, but to hear from others and to know some common experiences that were out there. So as we developed and moved around the province, we began to develop what we think of as a sense-making role and process that enables us to really capture the themes and the learning that are emerging from this storytelling efforts. So that work happened over time, and it really did allow us to really start to raise themes that we're seeing across stories, across communities, that were important from our perspective in terms of influencing change in the system. So we began to build relationships with our health partners, and we began to be recognized as an independent and trusted organization. And we're being invited to lead engagement initiatives for health partners like AHS or Alberta Innovates, researchers we partnered with, and several different initiatives with the Alberta government. Two recent examples of that in the last couple of years. In 2023, we supported a province-wide engagement initiative after being asked to do that with the MAPS initiative here in Alberta, the Modernizing Primary Care in Alberta. And that was really a chance for us to go and hear the stories of people's experience with community-based care, primary care, but also to identify what their vision of community-based care in Alberta might be. And we tabled a report to the MAPS Advisory Council, and out of that came a recommendation that one of the early investments of MAPS should be a platform like Care Opinion. And of course, then we worked with MAPS folks and the government, and also James and many of our supporters across the province to bring Care Opinion to the province, which is where we are now. So I'm going to just talk quickly about what's happened since 2024 when we got the funding, initial funding to implement, focused first on primary care. And we also wanted to at least begin to work in assisted living. So we started in fall of 2024 with 5 early adopter partners. And that was really a chance to check out how does Care Opinion work in a Canadian context and here in Alberta, and what can we learn from how we can to implement and support partners who come on as subscribers. So we ended up with starting with 2 PCNs, 2 primary care clinics, and 1 continuing care organization. And we worked with them to the spring of 2025 to kind of adjust and adapt to see what kind of training and support subscribers will need and how this fits with our context here in the health system in Alberta. So we did a lot of learning. At the same time, we started an evaluation process. It's actually 3 phases. John's actually been part of that evaluation process. We engaged an external party, a care lab out of University of Alberta, to design and lead that evaluation on our behalf. And that was important, especially in phase one, to capture what we were learning through implementation and working with subscribers. So that led us to the spring of 2025 when we actually had our public launch, where we went to media. We had an active social media strategy to try to open up and introduce Care Opinion to Albertans across the province. We did a number of things to try to do that. We were actually able to get some media attention, and we started to drive traffic to our website, which is obviously critical to capture those initial stories. Since that time, in the last year, we have now grown to 16 subscribers who are active members and participants in Care Opinion and can access the full array of services that Care Opinion provides, including the reporting that James has shown us a little bit about. We're really excited about recent subscribers that have come on just since April. Caregivers Alberta, I'll mention in a minute. We're really excited about Alberta Health Link that's just getting ready to launch Care Opinion within Alberta Health Link, which of course will allow Care Opinion to connect with over 1 million Albertans every year, which will be a powerful way to capture the stories and experiences of those folks who connect with that service. An interesting new partnership is with Chiropractic Association of Alberta. They've decided that Care Opinion is important for their work, and so they've brought it into their association to make it free as a service being offered to all 1,100 or so of their members across the province. So we're looking forward to working with them in partnership. And you can see that the subscribers go from far south, Chinook PCN, all the way to the northern PCNs like Aspen or McLeod River. McLeod River is probably our smallest PCN in the province, and it's one of our leading Care Opinion subscribers for stories captured. So we're excited to work with them as well. Let me just turn to Daryl. Daryl Gregory is here, Executive Director for Caregivers Alberta, and we wanted Daryl, because we knew he was going to participate, to just speak for a minute about, first of all, why capturing the voices and stories of family caregivers as well as patients is important, but also why Daryl feels that the platform is important for them going forward. So I'll just stop my slides for a minute, and I'll let Daryl have a moment. Daryl.
Okay, thank you, Don, and thank you, John, for the opportunity to talk briefly about family caregivers as contributors to patient care and why Care Opinion is an important tool to help us achieve that and advocate for that. So I want to just talk briefly by calling out the elephant in the room, and this is what we hear a lot, that family caregivers are a nuisance. And we know that. Healthcare professionals tell us that. Even caregivers tell us that. They're a nuisance because they're stomping up and down and trying to advocate for their loved ones to be included in the healthcare plan, to be recognized by healthcare professionals. We know that when we include caregivers as part of that triad of care, right, the caregiver, the care recipient, and the healthcare professional, leads to better health outcomes for patients. So it sometimes feels like there is a tug of war between caregivers and the healthcare sector in terms of family caregivers just wanting to be heard. And why are we partnering with Care Opinion? Why do we see this as an important tool? And I can talk about that by sharing another little story. I was speaking at an HR conference in Calgary on Tuesday about recognizing working caregivers in the workplace as a workplace issue, right? Because they're doing a lot of care responsibilities at home and still trying to work during the day. And we know that it is a huge workplace issue. And somebody had asked, well, how do we get this issue in front of leaders in an organization for whom it's not even on the radar? And we're going to do that by leaders sharing their story about why this is important, leaders who recognize it and can advocate for it. So that is the role of Care Opinion that we see value in caregivers sharing their story on the platform. Mostly good, maybe some opportunities to learn from. We can use those stories to advocate in the healthcare space to include caregivers in the healthcare team. So that's how we see using Care Opinion to generate those stories and use them as an advocacy tool.
Thank you so much, Daryl, for first of all, your partnership and your willingness to be an ambassador for Care Opinion, as well as seeing it as a powerful platform for the stories of family caregivers across the province. We really appreciate your work with us.
Absolutely.
So let me just touch on a couple of things we're learning so far. Early days, of course, we're about a year into our initial scale and spread of Care Opinion beyond our early adopters. We're reaching, this is mid-May data, but we're reaching 300 stories now.
Don, sorry, you're in the read mode, so it'd be great if you were able to kind of expand. So to use the slideshow, full slide mode would be, I think, make it easier for people to see, but if that's okay. There, that's fantastic. Thank you.
Sorry.
Yeah, super.
So some of the things we're learning already in the last year of data. So 47% now of our stories are actually subscriber related stories, which is really encouraging to us. We have a number of people that have found our website from all kinds of ways, and they're telling their stories. And when they do, we try to reach out to providers that might be connected to that experience who aren't subscribers. And we invite them to post a story through us, and we tell them about Care Opinion in the process. But now almost 50% of our stories are coming from subscribers and about subscribers, which is great, because then that leads to their ability to respond to them and to engage in building that relationship of trust and transparency that James was pointing to. One data that we like to look at, which is really interesting, we can track how many stories are referring to at least 2 or more services or programs in the storyteller's care journey. And now we're seeing over a third of those stories are telling stories, sharing experiences about more than 2 or more services. And for us, that helps us be able to look at trends around transitions, especially, which has always been a concern and a major theme in all the storytelling that we've participated in over these 11 years. So to have a mechanism like this where we can actually capture those stories and see what's happening in between the transitions between providers, and as Jane pointed out, then you start to encourage responding not just from one provider, but maybe 1 or 2 or even more providers, so that you get a richer understanding and insight about that person's experience and their journey. And the other metric that's really important for us is the last one. 20%, over 20% now of our stories have identified a change related to them, as one of the examples that James pointed out. This is really important for us because obviously we're here to listen, to learn, but ultimately we want to see change, positive change happen through these stories. And if already we're seeing 20% change in the stories that are referring to and related to our subscribers, that's a really positive metric for us. And of course, we want to see that grow as we develop further. The bottom graphs just simply show stories by sector. Not surprising because we focused on primary care to begin with. 51% of our stories are related to primary care, but 38% are related to acute care. And we have no subscribers yet and have not started really the conversations in acute care. We're only just doing that now. So we can see a major growth area for us in acute care and the need to have Care Opinion be introduced to that sector, because the stories are coming without any prompting from our part or any acute care provider in the province. We can also see there's about 5% for assisted living that we're just starting in. We have now 2 early adopters in assisted living, and about 5%, a little over 5% for other. That would include diagnostics and lab services, and a few other allied health services as well. And then the last one is simply around the divide between urban and rural. We track that information as best we can with the demographics that we can collect. And you can see the latest stat that I think I know around the split is about 19% rural or small town in Alberta. And we are tracking right now about 34% of our stories are coming from that area, which is encouraging to us. And I think that's going to be important to track various demographics as we're able as we go forward. So just one other quick piece of data. 96% of our stories are coming through our website, which is in the way that most people connect with us and share their story. But 4% are done by a 1-800 number, by telephone, where they talk to a person on the other end, and we capture the story through that conversation and then post it on the storyteller's behalf. Who's sharing the stories? I should say we're also developing a leaflet now. We're testing in Bashaw to see if people would prefer to write out their story and submit it that way. So we're testing that as well. 77% of our stories are being shared by the patients themselves who experienced sharing their own experiences, but 11% are caregivers who support them, and 12% are other. That includes family members, friends, and other folks that might be sharing a story on behalf of someone else. And a stat that's really important to us is among subscribers, 100% of our stories have been responded to. And that, of course, is a major goal for us, and we want to keep that trend going. So one last thing I'll just talk about briefly. We've just completed phase 1 of our evaluation that I mentioned earlier, and that was focused on the implementation, and 4 key findings have emerged. We just have now the final executive summary that we're going to be publishing and certainly sharing widely, so happy to share that with others now. But these are 4 of the key findings. Shared values drove early adoption. Our early adopters, the people that come to us early, are committed to listening to the experiences of patients and their family caregivers. And that clearly was evident in how people came to us to want to be part of the process. And we're seeing that quite widely. Implementation requires relationship and support. It's not quick, and it takes time to develop, and it's really important that we customize our support so we can provide the kind of training and ongoing support and coaching that allows folks to get over the initial hurdle of nervousness and anxiety around what we're going to go public with stories, and we're going to be on a website responding publicly. And as James says, after people get time and get some support, it's quite remarkable how this whole thing changes, and the idea of contributing to a more trusting and transparent relationship online becomes quite powerful for people. From the storyteller perspective, we know what we're hearing clearly is that storytelling creates meaningful learning opportunities, both for the patients and those who are reading the stories, but also for the providers who are receiving them and thinking about change. And as I said, the last key finding is acute care represents a significant opportunity for expansion, and we are just starting to work on that now with our first conversations in the acute care sector. Last thing I would want to say is that this is a quote that comes from the evaluation about the power and the importance of narrative feedback and why it matters. And it's not that this replaces all the ways we engage with patients, but it is complementary and maybe a unique data set that we haven't had access to in the same way as Care Opinion can bring to Alberta. So the quote's traditional patient experience surveys provide important quantitative data, but it cannot capture the complexity of health experiences, including communication, relationships, emotions, and trust, and how care is experienced over time. So that was a very helpful comment in our evaluation that we've just received. What's next in terms of the evaluation is we're focused on phase 2 and 3 the next year. And we're really going to focus more on outcomes and impact over time. And that includes what happens as this listening and learning scales up, and what kind of implications and impact can that have. So we're very much looking forward to that. I'm going to stop now so Molly can have a bit of time, but we will post our website, careopinion.ca, in the chat. And also, if you're interested and want to contact us, you can email us at info@careopinion.ca.
Yeah.
Thanks.
And thanks so much, Don. I'm glad that we had this engagement, because there's a number of organizations to follow up. So we'll certainly be doing that. I think it's really exciting. And and also a bit of time, but wanted to allow Health Quality Alberta to just provide a couple of comments in regard to the initiatives that they might have underway. But Molly, over to you. Is she here? Where is Molly? I don't know if Molly dropped off. There she is. You're muted, Molly. You still are muted for some reason. I don't know why. No, you're muted.
How's that?
That's good. That's good. Thank you.
Okay. I just wanted to share that Health Quality Alberta has 3 key mandates. One is around patient safety, and certainly as
Catherine led us off thinking about the importance of listening to patients, and James made the connection to people's comments do actually shape safety within our healthcare system. A second mandate that we're interested in is quality healthcare services, and we have a new framework which is on our webpage, which is updating the quality dimensions, the dimensions that describe quality health services. And in the middle of that is person-centered care. So really thinking of how both the people receiving care and the people providing care are experiencing the healthcare system is important to Health Quality Alberta. And our third mandate is around this concept of person-centered care, recognizing that it is not just the patients, but the patients, the families, the communities that surround the people who use our healthcare system, and how the community contributes to people's health as well are the key concepts that we're interested in at Health Quality Alberta. We do, as Don indicated in his last slides, we run a large number of patient experience surveys in primary care, in continuing care, in emergency department, and we access the data that is collected currently by Alberta Health Services in the acute care. And we find overall that in those types of surveys that about 80% of the people who respond rate their overall rating of care as quite positive. But we became interested in what about the voices of the people who don't rate their experience particularly well, and have started doing some very interesting analysis called latent class analysis, looking at those voices that are lesser heard, because it's there that the greater opportunity for improvement can occur. And through qualitative studies in supporting or looking at the attributes of the people and how they answered those questions, are able to identify for providers of health services some opportunities for improvement, and often it is around communication. So we also are asked to respond to do reviews for ministers of health. And so about 5 years ago, we did a review of the patient concerns management process within Alberta. And our key 3 findings were, James, exactly what you proposed Care Opinion is after. So the first finding was how to make your concern known is a confusing process in Alberta. There are many places and it is a confusing process. And people don't always feel that they're treated with great respect while they're making their concerns known. And the third and most interesting to me is that people are often motivated to make their concerns known because they want to see a change in the healthcare system. And our finding from that review was that patients have very little evidence that change is happening because of the concerns that they have expressed. So they take a deep breath, they make their concerns known, and then there's no evidence that the system is changing. So I'm greatly interested in the work that Care Opinion is moving forward in shifting cultures towards listening for the voices of patients and families, patients and care providers, and the staff themselves in how we can shape and improve the quality of our healthcare services within Alberta. So if we're about to, John, that was all I wanted to say today. But I had a question for James, but I can either...
You got the privilege of the mic, Molly. You can ask a question.
So I have been thinking about this way that Care Opinion has of shifting culture, because of course we all want a just and trusting culture and where people feel psychologically safe to express their concerns, both staff and patients and family caregivers and others. And I have a suspicion, but I wonder, James and then Dawn, if you could comment on what is it about the format of Care Opinion that is influencing a shift in culture that other concerns management processes have not been able to see.
And just to comment that we've got about 6 minutes left, so you should be succinct in your response to the question, James and Dawn.
Okay, well, succinctly, the short answer is probably that I don't know. I wouldn't want to overstate the changing culture. It's not as if we've been able to measure that or see it some widespread change, but it's just that we have these straws in the wind. We hear these things people say. One of our subscribers said, since we've been getting feedback from patients online, we've found that we're giving each other more positive feedback. That sort of modeling back the other way. The patients are teaching us how to behave differently. These are just really interesting things. How that happens, I don't know. I think part of it is constantly being clear about our purpose and trying to build software that supports the relationships that we want to see and the values that we want to see, rather than supporting something else. So we think carefully about what we add to the site, but we also think very carefully about what we're not going to add to the site, because we want to keep it on mission, if you like. I think that's part of the answer, at least.
I think that's an excellent answer. I'll just add one thing, and James referred to this in his presentation, I think in a couple of ways, but I think what we're finding is that care opinion definitely represents a reciprocal relationship, and that reciprocal relationship builds a level of trust and transparency that I don't think people have experienced in the same way before, and I think that naturally opens up the conversation, respecting the stories, the fact that the stories are 70% positive, I think makes a difference. That people were at one time very concerned about it, but as they get engaging with the stories, even the stories that have things to learn from in terms of things not going well, there's a sense in which there's a relationship we're building here. And I know from the storyteller's perspective, they also feel that in terms of, well, look, people are responding publicly. They're actually not shying away from this. And I think that reciprocal relationship is what makes a big difference.
Yes, thanks. And I do think, James, you highlighted in your presentation, because I remember in my early discussions with you when we were sharing, is the immediate concern is, how the provider organizations or the subscribers or those respondents were going to be significantly resistant to having this kind of avenue of a flood of people opinion. So if you might have a quick comment on that before I close, about the overcoming that kind of expectation of the mess we might get into if we kind of become open to being responsive and the workload. So if you had a comment.
Yeah. I think that's still an open challenge for us. I don't think we have overcome it. I mean, in a sense, we're furthest along in Scotland and Northern Ireland, where a policy decision at a senior level has supported. It's not just that they paid for the platform; it's that they've expected people to use it. They've encouraged it and supported it and given permission to people to use it, and gradually, therefore, staff adopt it and they use it, and this becomes the new normal when people say, well, this is just what we do now, and we like it and it's good and we can use it, and that overcomes the resistance. Now, that hasn't happened in other parts of the UK yet. It has in some English NHS trusts, but there are still, the vast majority of trusts across England are still either indifferent about online patient feedback or actively hostile. So, that is a battle we're a long way from winning in the UK still. And we don't expect it to be quick.
Yeah.
Although 20 years seems a fair old time to wait, but still, there we are.
And hopefully we can be an example of expansion and advocacy, building off things. And I would note to everyone that the James and the Care Opinion UK generously shared a lot of their lessons and learnings and the platforms and the software they're able to use to solve all those particular problems. So we're building on that. And I do think my big phrase always in policy development is we need more gardeners, not florists. And we often have florists who kind of pick an issue in very short term. We might have a government funded public consultation of roundtables, and they produce a report, and then it's kind of not dealt with. And I do think that we need to develop sustained programs where the seeds are planted, like Dawn has done with some isolated things, learned how to grow and do some particular learnings. And I think it may not reap benefits in the first year, but it's starting to reap it now. And I think we're at a significant pivotal point to spread this in Alberta with strong support and advocacy, but also with some notes of people interested, perhaps as we develop perhaps some coalitions and learnings across the country. But please, everybody, we'll be following up and sending you the slides and the recording and the links to what was mentioned here. But please join me virtually in applauding and thanking our participants for talking about this important subject. And thank you, everyone, for joining us.
Thanks so much. It's been great.
Thanks all. Appreciate you being
Thanks,
here.
everyone. Have a great rest of your day, and I will be ending the event now. But thanks to colleagues and friends, and this was really fantastic. And special thanks to James for taking time away from a birthday to be able to share your learnings with us. And all the best.
Thank you
Pleasure.
all.